We don't really think that worrying about it makes people have infertility. We actually think it's the infertility that gets you all stressed out. There's plenty of evidence that stress doesn't really cause infertility unless it makes you stop having sex or stop having periods. All right. So don't let anybody tell you it's your fault and don't let them make you feel bad. So if you are over 35, you should try for about 6 months before you seek evaluation. And if you're under 35, a whole year. And boy, that can be a long year, I know. um, However, there is one qualification there. If you're a woman who does not have really regular cycles, you can't figure out when your fertile time is and your periods aren't happening or they aren't happening regularly, you don't need to wait. But if you're having regular cycles and you're trying to get pregnant, humans are just not very good at getting pregnant, and it can be very normal to take a few months. So if you're over 35, we would say the 6 month mark would be the time to get in and get evaluated just to make sure there's nothing serious that's getting in the way of getting pregnant. There isn't a lot of time to fool around with this at that age. It's easy to come and see us. You just call up and make an appointment. You don't need a referral. You don't need anybody's permission. You can just come and see us. The number is 614-451-2280. And we're also actually really easy to get to. Our location is right by the intersection of a bunch of highways and very easy. So no issues. Anybody, we're open to seeing anybody. No referrals, no problems. We can always get your records to look at, and we don't necessarily need to repeat things that have done before. We're just going to try to hit the ground running and make things better for you. And I don't think you have to wait too long to get a new patient appointment here. I don't think it's more than a few weeks. We have 4 doctors here at Ohio Reproductive Medicine, and we're all, of course, ready to see new patients anytime. Well, typically the first line of treatment is a pretty simple and pretty inexpensive treatment, and that would involve using some long established medications that are in a form of a pill. They've been around for years and they're not terribly expensive and they're pretty easy to take. You just take them for a few days. And we might or might not also begin with intrauterine inseminations. We sometimes shorten that to IUI. Infertility caregivers, we love to give things nicknames, and I'm going to try not to do that. But so we would do inseminations potentially and use these medications that I mentioned. That would usually be the first line treatment. But as always, treatments are very individualized and not that wouldn't be appropriate for all of the people that we see. So first, you have to have an evaluation. It doesn't take that long, but there's some basic, tests that we need to do.
Essentially what needs to happen to get pregnant is the brain and the ovary need to communicate back and forth. The brain tells the ovary by sending hormones to make an egg. That egg grows and it gets released. That's called ovulation. And then the fallopian tube has to actually be able to pick up the egg, and then the egg moves carefully through the fallopian tube, and then that's where the sperm meets the egg. The egg is fertilized in the fallopian tube, and then that fertilized egg travels through the rest of the fallopian tube and implants on the wall of the uterus. And so our infertility evaluation is basically geared around looking at each one of those steps. And so, to look for ovulation, we may do hormonal testing. And sometimes we have a good sense of if people are ovulating just by talking to them and them, do they have regular periods? Or are they irregular? Are the cycles long? How many days, does it take from the time of ovulation until she has her next period? So those are some of the things that we talk about to try to identify if there is any hormonal issues going on. The next thing that we think about is the ovary. And it may be worthwhile to just spend a minute talking about ovarian reserve testing, because I think that this is a really confusing part of the infertility evaluation. And ovarian reserve is an idea about how many eggs a woman may have left in her ovaries. And the ways to look at ovarian reserve can be by doing a day 3 FSH and estradiol level. by checking an AMH level or an anti-Müllerian hormone level. So these levels, like an AMH level or an FSH level, talks about how many eggs are left. It doesn't necessarily talk about the quality of the eggs. So that probably age is a better determinant of sort of egg quality, and the ovarian reserve is an idea about how many of the eggs are left. Sometimes they'll you'll also have what we call a pelvic ultrasound to look at an antral follicle count, and and those are all ways to look at ovarian reserve. And the other thing I want to make sure that people understand is ovarian reserve testing is very important. Actually, it's like really important when we think about preparing someone for an in vitro fertilization or an IVF cycle, but it doesn't necessarily tell us that that's the reason why the woman's not getting pregnant. But it can guide us a little bit in sort of understanding other testing that may need to be done, or understanding how fast she should go through treatment, and sort of any other medicine dosing that she may need. The other thing to think about is doing a fallopian tube test, or an HSG, or a hysterosalpingogram. That's the X-ray test to look at the tubes to make sure that the fallopian tubes are open. It's important to talk to the doctor if you let us know if you've ever had any infections in the pelvis before. Sometimes we'll also do a pelvic ultrasound to look at the uterus, to look for fibroids or polyps. And then, often if there's a male partner, then we would do a semen analysis to look at the quality of the sperm. And the semen analysis looks at the volume of the semen. It looks at the amount of sperm that are there, and then how well they're moving.